Hi, this is Dr. McClellan. Welcome to week 4 and the clinical application of Gate 1. Up to this point, we've been emphasizing that grief is not a fixed sequence and that bonds do not simply end when a person dies. So now we're going to add on to that learning with another responsibility of clinical social work in grief and loss, which is assessment. A grief assessment must do two things concurrently. It must protect the dignity and meaning of the person's grief, while at the same time, it's helping us to notice risk, impairment, trauma, and the needs that require a more focused response because presence without that precision might miss danger, and precision without that presence is going to reduce that relationship to a symptom list or a checkoff box, that's really not going to engender or enable a relationship in which a core helping relationship can occur. So as you move through this video, I want you to hold this question. How can I gather clinically useful information without acting as though I already know what this loss means? So assessment begins before the first formal question. It begins really in our pace, our tone, our posture, and our willingness to tolerate uncertainty with the client. Clinical presence tells the client that their grief is not going to be hurried or judged or forced into a familiar story. Clinical precision is not the opposite of warmth. It's the disciplined effort to understand what's happening across those multiple domains of time and functioning, of safety, of relational safety and presence, of culture and development, and the person's own meaning making. Precision means noticing what we don't yet know. And when these things work together, our assessment becomes collaborative. Within this respectful relationship, we can ask direct questions about sleep or suicidal thinking, about traumatic images or substance use or daily functioning while still communicating respect. The goal here is not to prove that grief is normal or disordered, right? The goal is to understand this person right now, in this moment, in this context, well enough to decide what attention is needed for them next. So this type of multidimensional assessment really helps us to resist the temptation to explain grief through one favored lens. If we start with the body and the mind, we can consider things like sleep, appetite, concentration, somatic distress, mood, trauma responses, and obviously regulation, right? And then we can attend to relational issues like attachment, caregiving roles, conflict, family communication, continuing bonds. All of these things might have been disrupted by the grief incident. Third, we look at culture and spirituality, which in my mind really includes a deliberate attention towards faith. What does loss mean and look like? What is mourning like? Who is permitted to grieve openly? And which supports feel solid and trustworthy? Finally, systems and time matter as well, like housing and work and healthcare, immigration, discrimination, financial strains, developmental stage. Even the timing of multiple losses can really amplify, or constrain our adaptation to loss. So these are not boxes to check off, they are interactive domains. So a sleep pattern might reflect traumatic arousal or caregiving burden. It might be a result of a disrupted ritual or several of these things at once. This intentional assessment widens our lens so that our eventual formulations not prematurely narrow. Differential assessment is not a contest to identify the correct label as quickly as possible, even though sometimes is what it feels like when we're studying for our clinical exam or focusing on the DSM. Differential assessment is really a process of asking which patterns best explain the person's experience. And that leads us to information that might indicate which response would be most helpful. So with grief, we know a differential assessment is going to focus on sadness, disrupted sleep, concentration difficulty and withdrawal, perhaps yearning and moments of disbelief. And those features alone obviously indicate grief, but they don't settle the question because depression may appear more pervasive and less tied to reminders of the deceased than you initially assume. Trauma responses may center on threat, re-experiencing of trauma, avoidance, or even physiological alarm. Prolonged grief concerns require our careful attention. We need to pay attention to duration and cultural and contextual expectations. Is there an acceptance of the grief experiencing they're showing to the world in their culture, in their family, in their community, in their school, wherever they are? Is there persistent separation distress, identity disruption? Is there significant impairment in their activities of daily living? Additionally, we want to make sure we're paying attention to comorbidity. Context here remains essential. Ask them how symptoms move, what triggers them, what remains meaningful, what functioning has changed, right? What screening measures you're using when appropriate are going to be important here. But you're not going to let a score replace a clinical conversation. I used a perinatal grief assessment with a client who had lost an infant the other day. And as we went through that assessment, she did score highly, and that was important clinical information. But it also offered a way into some of the grief that she was experiencing because the questions named some of what she was feeling. The one I remember most distinctly was a question about whether she felt an important part of her died with the baby. And she totally agreed with that, a 5 on a Likert scale, 1 to 5. So that was really a window into something she was experiencing that the assessment gave us, she and I, collaboratively to utilize in session. So the screening measures are appropriate, but they don't replace the relational conversation that occurs. In my doctoral dissertation, I focused on risk and resilience, and I strongly believe that we should be assessing risk and resilience together. So risk is important to assess. We need to identify any suicidal thinking or self-harm, substance use, violence, neglect, self-neglect. If we identify a severe functional decline, traumatic exposure, if we see some biological markers or social isolation or barriers to care, we need to assess that risk. We need to identify cumulative losses that have added up and the way that systemic stress around the client or their family might be intensifying their grief reaction. And at the same time, resilience is so important to identify and counter those risk factors. My hands aren't big enough to show you my talking with my hands, right? So resilience is more than an individual trait. It may live in our relationships, in our faith, in our cultural practices and humor, our routines, our mutual aid practices, our caregiving, our memories, our advocacy. Even in our ability to ask for help lies resilience. And so a person can be deeply distressed and still have significant strengths. We need to highlight and uplift those strengths. A person who feels highly capable might still be at risk, though. So both parts of the spectrum are important and must be uplifted and examined with curiosity and compassion, collaboratively with the client. We're not going to turn protective factors into a reason to minimize suffering, though. We're not going to say, oh, but you always are able to see beyond today or lift your chin up or whatever it is, right? We're going to ask how supports actually function. It's lovely that your faith community has lots of available resources, but are they available right now when so many are in need? Are the supports actually functioning? Are they available? Are they culturally congruent? Do they reduce isolation? Do they create obligations or conflict? This assessment task is very delicate and layered and complex as we seek to understand both pressure and protection so that the next steps we identify collaboratively with the client fit the person's real ecology right now. So let's go back again to the Alvarez family. And in our first assessment encounter, notice how easily one family level story could really obscure several different grief experiences because Elena might have a migration history and faith and earlier losses that she's managing. Marisol might be balancing care and work and parenting and her own grief. Javier's place in the family system might be complicated by his own relational history, and Lucia and Mateo may communicate grief through their identity questions, their silence, their bodily complaints, perhaps. You'll see that often in children, or school concerns might elevate their issues. So we're not going to treat these possibilities as facts, but they become prompts for inquiry. We would begin by asking what changed for each person and what changed between them. We'll explore among these family members which expressions of grief are welcomed, which are misunderstood, who's expected to remain strong, right? And we have to ask about the safety and functioning directly in order to uncover some of this, while also noticing resources and rituals and protective relationships. I was working with a family recently, a mother and her three children who were dealing with the death of her husband and their father. And in the family work that we did, when we were doing this type of assessment, we identified that the children who are older now, teenage kids, the oldest being 21, were uncomfortable and felt unable to express their grief directly to their mother because they felt as though they would be adding more to her plate, right? So they thought they were being protective, but that was actually inhibiting the communication and the functioning in the family. But we didn't identify that until we went through this careful assessment. So your practice task this week is to draft 5 grief assessment questions for the Alvarez family. And you're going to aim for questions that really open up the story rather than steer the family towards a particular outcome or explanation that you believe is coming for them, right? Some preconceived notion you have in your head. And you definitely want to include one or more than one, rather, of the domains we talked about. You want to ask questions across the domains to be comprehensive in your analysis. You want to ask what's changed in the body or the daily routine, maybe, or, we talked about what the loss might mean to each person, how each family member understands and expresses grief individually, and how they manage that collectively. What supports really feel available to them right now? Like some friends are saying, call anytime, but do they feel comfortable calling? And what scenarios are really becoming difficult or unsafe for them at this point? Is there any self-harm, that kind of stuff? And please do make sure you include something about culture or spirituality or faith in the family's own language here. Then you're going to review your own wording. Does it seem to assume that everyone wants closure? Like, are you trying to steer them towards a resolution in some way? Do your questions seem to imply that visible emotion is healthier than silence? Like, is one type of grieving more acceptable from your clinical lens right now? Do you want to make sure you address that? And does it presume one family member can speak for the others? Are there clear questions about safety? Strong assessment questions are not just sensitive, they're also very purposeful and intentional. We need to be comfortable asking these kinds of questions about suicidality and self-harm. These questions need to help us understand something that could shape our formulation, our referral, our pacing, or really the next clinical conversation. So just be thinking of all that as you develop these. Okay, so To summarize then, the central idea for this week is simple but very demanding. You need to be present enough to hear and precise enough to notice. Presence keeps us from reducing grief to a checklist or timelines or professional certainty or outcomes that we have in our mind that may be designed to help us stop feeling the discomfort of the person in front of us and the grief they're experiencing. Making sure, though, that we pay attention to the precision of our assessment keeps us from overlooking any danger. We want to address impairment or trauma that needs and deserves action. Our grief-informed assessment is going to hold multiple truths at once. Pain may be an expression of love. Cultural practices of the family in front of us may differ from our expectation as the clinician, and that's okay. Strength may coexist with serious risk. And a diagnostic framework can be very useful without being the whole formulation. Not knowing yet is an ethical position when it leads to better questions, okay? And as you begin the Alvarez family assessment, please do distinguish observation from inference as we pull apart facts from opinions. You want to name risk and protection, attend to relationships and systems, reflect on your own urge to rescue as you write these questions, reflect on your urge to reassure or diagnose or move quickly through this. When you feel that urge, recenter yourself and let curiosity create the conditions for sound clinical reasoning, okay? Just calm down and slow down and be curious. Okay? I hope you have a wonderful week.